refusal is not actually a psychiatric disorder and doesn't have a diagnosis per se. It's really more a behavioral description of what somebody is doing rather than something that someone has. Sometimes it's called school phobia, school refusal, or sometimes it's just an anxiety disorder. And we'll talk some about comorbidity as we go through this. Next slide. So the reality is it's pretty common, 1 to 5% of all school-aged kids, similar for boys and girls. You see it typically come out when kids have to make a school transition, so like from preschool into first grade or from elementary school into middle school. Not really a socioeconomic difference unless we sometimes are alert to it differently in terms of parent awareness and availability. We often see the younger kids present with a variety of worry symptoms. The teenagers can have worries, but also some mood symptoms. And that really reflects more the age of onset of other kinds of psychiatric difficulties. Anxiety is really common in school-aged kids, elementary school-aged kids, and true mood symptoms tend to start around puberty. Although we do see them in prepubertal kids, we see a lot more of them in teenagers. Next slide. Next slide. So these are kind of things, and maybe some of these things ring true for the kiddo that you were seeing. We often see it after a holiday break or the summer, or say the kid's been home with the flu and then they have to go back to school. Sometimes we even see a difference between a Friday and a Monday. Parents will say Sunday nights are nightmares because the kid just is having a cow about having to go to school the next morning. They get through Monday, Tuesday, each day gets a little bit better, and by Friday it's okay, only for the weekend to come again, and then they start all over. Sometimes, too, you can see it, the morning is a nightmare, but by the time the afternoon comes along, they're okay. I think of the 3 W's, whining, whimpering, and weeping is often kind of how it's presents. And if you ask parents about that, they can usually validate that. And then when we think about the somatic symptoms, because it's often the somatic symptom that gets the kid into your office as opposed to my office, right? They may come in, they have headaches, or they complain that their heart's beating too fast and they feel shaky, or they get GI stuff and they think they're going to throw up and they can't go to school because they might throw up. Or they spit up, just a little bit of saliva, and then they tell their family that they threw up. They can't possibly go to school that day. Or everything aches them. They can't walk because their legs hurt, or things like that. And then sometimes, not as a somatic symptom, but we see the tantrums. And those I like to think of as small, medium, large, or extra large. And that's often how I ask families about it. Is on a scale, is this small, medium, large, or extra large? Because that'll tell me whether I need basic parenting skills or industrial strength parenting skills. And those are the words that I use because that makes sense to parents. Okay, next slide. And obviously I don't think I have to tell you guys, why do we care? Because although sometimes we have to help a family care because sometimes they're okay with our youngsters staying home. But obviously they have to learn content, but they also have to practice their social skills with peers. That's a huge part of what school is really about and why we ask them to spend so much time there. There are also non-academic opportunities, whether it's in the arts or sports and all those kinds of boosts for self-esteem and practicing peer interactions and developing skills that kids work on in a school setting. And also, if you don't finish elementary school, it's hard to go to middle school, and then it's hard to go to high school, and then it's hard to do anything beyond that. And so it really does potentially impact what can happen if the kids are falling behind and falling off their developmental trajectory, which at the end of the day, every time you guys see a youngster, your main job is, are they mapping out along their optimal trajectory? And if they're not, what has caused them to fall off that track? And how do I get them back on it? But the other thing we need to think about is the impact that school refusal can have on the family. And often what we see are parents who no longer feel they're in charge of their household and that the kids are driving it. And that's not good for the kids or the parents. We often wonder about who are the other kids in the family who are getting forgotten when this kid's having a major meltdown and causing a scene every Sunday night, and the hyper-responsible youngster or the parentified kid is sitting quietly in their room with nobody paying attention to them. Families are often exhausted in dealing with this because they often don't come until it's gotten pretty ugly. They don't necessarily raise it until kids, as you said, are running away from school and that the stakes are suddenly much higher. But they also parents will often feel like they failed. You know, parents' jobs on some level, they have to feed and clothe and house their kid and get them to school so they can learn. And not being able to get your kid to go to school is kind of a fundamental failure, if you will, for a family. And so they can feel very defeated by the time this comes to attention and in terms of how they've been navigating it. Next slide. So, like all good clinicians, we want to know how did it get here and like what's the etiology of things like this. And really, it's very multifactorial and heterogeneous, and it depends on the individual situation. The overarching concept that I would suggest is that the behavior is serving a function for that youngster and that family. And our job is to try to get a handle on what that is, because if we can understand the antecedent behavior consequence sequence from a behavioral standpoint, we have a chance to leverage it differently and shift the pattern that shift what's getting reinforced and refocus that in the more desired direction. So sometimes it can be that a youngster wants to avoid something specific at school, like they have performance anxiety and they don't want to take a test, or they don't want to eat in front of other kids in the cafeteria. They don't want to use the bathroom at school. Those may be attached to specific anxiety disorders that we can talk about. They may want to stay home because there's something very aversive at school. Maybe they're being bullied, or maybe there's a really mean teacher, or maybe they have a learning problem that hasn't been identified, and so they constantly feel dumb. And most kids will do anything they can to avoid feeling dumb, including not go to school. Maybe they're worried about being separated from a loved one in terms of like a separation anxiety, and they might be worried about their mom or their home. Maybe that's a realistic worry for some of our youngsters. Maybe there is violence. Maybe there is an unsafe situation, and they feel a responsibility to protect mom or keep an eye on mom. Maybe it's not realistic, and it's really more of a function of an anxiety disorder. The other thing we see is that anxious kids tend to have anxious moms, and sometimes moms don't like to have their kids away from them. So if the kid looks, blinks funny, the mom says, oh, I think you might not be well today. Maybe you should stay home, because it really has more to do with what the mom needs rather than the youngster. And so we see overly anxious parents at home, and then the kid staying at home can serve a role for the parent rather than for the child. The other thing we can see is that school refusal can be simply an attention-seeking behavior, although granted it's not a very adaptive one. And maybe that youngster only gets attention when they make a big scene, only gets attention if they can stay home during the day when their siblings are off at school. And maybe negative attention, even if they get yelled and screamed at, is better than no attention at all. So all of those things could be going on, some of them or some variation of those. And how you intervene depends on how you've understood the behavior as serving a function for that child and family. I think that there's a lot of overlap with other psychiatric difficulties. So school refusal can be part of separation anxiety. It can be part of generalized anxiety. It can be part of social anxiety. It can be part of panic, either with or without agoraphobia. It can be part of a learning disability or intellectual disability. It can be part of OCD. The kid who can't touch the doorknobs at school because there are so many kids touching them and filled with germs can't go to school because it's too risky. Kids with depression and dysthymia may also not want to go to school because they don't have any energy. They don't want to get out of bed. It takes too much, and they just can't do it. Sometimes kids don't want to go to school because they just want to be in conflict with you. And again, that could be because it's the only way to get attention. Maybe something terrible happened at school. They were assaulted in the bathroom or something, and they have a PTSD. And so when they go to that environment, it triggers reminders that make them very, very uncomfortable. Or an adjustment disorder or a substance use disorder that is pulling their energy in some other direction. Next slide. So, like all good situations, we ideally have a comprehensive evaluation. In some ways, to do two main things, I would say. One is to think about, are there any of those other diagnoses going on that deserve treatment, focus, things like that? but also to think about how is this impacting the family, and where does the family need supports, and where does the family need skills. So sometimes the family is undergoing an enormous amount of stress, and they need some social supports, resources, things like that to be able to move forward as a family and get everybody back on track. Sometimes our families need some parent management training to understand behavioral patterns and understand what antecedents, behaviors, and consequences, what things are increasing the likelihood of the behavior recurring versus decreasing the likelihood of the behavior recurring. Ideally, we'd have some understanding of the cognitive capacity of the youngster in case that was impacting it in some way, and whether there was any other kind of major event, substance use, sexual abuse, physical abuse, things like that, that was sort of an added layer of complication that we needed to think through. There are different scales that you can think about. You can go to the next slide. And I don't know if are you guys familiar with anything on this list?
I don't think so. Not really.
Okay, so SCARED is I forgot what it stands for. It's an acronym. People who make scales love to make them say a nice name. But it's basically an
for childhood anxiety-related disorders, I think it is.
Okay, so it's basically an anxiety scale. It's a self-report, youngster and parent, that asks them to rate whether or not they have a particular worry. And then the sentences are all mixed up as to what kind of anxiety problem it could be, and then the way you score it, there's a threshold for each of the different childhood anxiety disorders, and it can help you, based on self-report, figure out whether a child might have something. The PARS is the Pediatric Anxiety Rating Scale, and that's in the public domain. That is a little bit different. It's a clinician instrument in the sense that you ask the youngster, you ask the parent, and then you make a clinician best estimate of whether you think it's present or not. And it asks both about severity but also frequency. And then the Child Behavior Checklist is a very broad behavioral assessment that a parent fills out and a teacher can fill out as well. And it has various domains, introversion, extroversion, how naughty and anxious, worried, depressed, things like that. And so you can get some feedback from that. And then there is a particular school refusal assessment. I'm not as familiar with that. Barbara and Ray, are any of these within Chattis?
Yeah, SCARED, the SCARED we like because there's a parent and child version of it. And I really like that when used a lot. It's in Chattis, and CBCL is in Chattis. Mm-hmm. I'm not familiar with the school refusal assessment. I'm curious to hear about that.
Yeah, I'm not familiar with it either, but apparently it exists. I think what I struggle with around thinking about that is we typically know if a youngster is refusing school. But I want to understand a little bit more about what could be driving that. And I think the SCARED, the PARS, and the CBCL are probably a little bit more helpful than to try to drill down and to figure out what could be going on that's contributing to it.
Out of curiosity, where could we get access to these?
Well, the SCARED and CBCL are in Chattis. The CBCL is proprietary, and you can access it online. There's a cost to it. Okay. The PARS, as Emily mentioned, she didn't happen to mention that the famous Dr. Riddle from Johns Hopkins, who is a close relation to Emily, was one of the authors of that tool. And I don't know about the school refusal assessment. Is that available?
Okay. From an intervention standpoint, the most important thing is getting the kid back into school, even if that sometimes means standing on the front steps of the building as step one. We try to avoid home and hospital teaching or a note excusing the child from school. Once we sort of go down that road, it's super hard to get the kid back, and sometimes the family as well. Sometimes we hear families who say, well, I'm fine doing homeschooling. I usually worry then about what kind of reinforcers the whole family is getting from the youngster being at home, and sometimes there's not much we can do, but I certainly talk with them about why I think being at school is important, and if it's not the right school, then let's find the right school. I think the other thing that can happen with these youngsters is they can, unfortunately, if they present with a lot of somatic symptoms, they can get a lot of medical treatments and evaluations, which can sometimes medicalize the maladaptive coping in a way that families can become overly invested in finding the solution from a disease standpoint when that may have nothing to do with what's going on. We can go look at the next slide. So the most common interventions are really exposure-based treatments, which don't have to do with understanding why the child might feel conflicted, but really focusing on the behavior and accepting that, yes, it is scary, it is hard, and so we are going to practice. And that may include some systematic desensitization with graded exposure. So like being in the classroom and sitting at their desk could be a 10. So let's, but a 1 is standing at the front door of the school. And so you can build a hierarchy of that and begin to work kids through it a step at a time. We often do some relaxation training to begin to help them develop some deep breathing and other kinds of coping. We may do just some imagery. Imagine you're going into your classroom before we actually ask kids to do it. We develop contingency management plans. What will you do if you start to get anxious? Instead of running out of the building and going home, what are some alternative options? And everybody in the school needs to know what they are so they will support the implementation of the contingency plan rather than just let the kid run home. In some ways, the other thing that can happen is when the kid runs home, it's often easier for the school, because having a kid who needs behavioral intervention and a contingency management, everybody needs to know, everybody has to work on it, is a lot more work, actually. And so we really need to make sure that there's a team. Sometimes we have to do social skills training with the kids because the situations that are making them uncomfortable at school have to do with peers. And all of these things that can be part of a cognitive behavioral burst of care, and anywhere from 12 to 16 sessions or so. And really that has to do with teaching the link between what you're thinking, feeling, and how you're acting. And then it's about skill development and practice. And key in that is rewarding progress, rewarding anything that approximates the desired behavior, which sometimes is hard for families to do. Sometimes there's a role for supportive therapy, helping them understand what it is they have. It's a real thing. We're not saying that it's not real. It's a real thing, but there are ways to fix it, and that can be relaxation focused. And the other thing I would say is that for a lot of the interventions, the adults can be the focus of intervention, both how to reward the desired behaviors, ignore the others, and then specific recommendations for how to ramp up that return to school, that return to expectations about work as well. Next.
Emily,
Yep.
while systematic desensitization is something, it works for a lot of these things, is there still a role for emergency get back on the horse? Maybe the mom is overly anxious and we need to send a policeman or somebody who's pretty matter-of-fact about it to get them back in that environment, because the more time they spend at home, the harder it is to get back on the horse. And so that's sort of a different kind of approach.
I think that you have to really assess the family and the school. Because if you do that once and then don't do it again because everybody flips out over it, we potentially have made it worse. So I think that those kinds of interventions can be very, very powerful and effective as long as everybody's on board. Right. And so you really have to do your homework, I think, to make sure that it doesn't turn into a big scene that makes it sort of drives the affect up even more. With parents screaming at the policeman and, you can't do this. And, so you really have to know your family about whether they could tolerate it or not.
Absolutely. It's interesting. I've worked with quite a few kids with school refusal, and the schools, with the ones I've dealt with, have been extremely supportive. And in some cases, the assistant principal came to the house and picked the kid up. But getting another adult who doesn't have the emotions associated with the problem, sometimes a next-door neighbor is important. And actually, some of the data about school refusal indicates an imbalance between the mother and the father in the family. And sometimes just getting the father to step up to the plate, change his work schedule, take the kid to school himself, is a great support in the situation and starts to shift some of those dynamics as well.
Absolutely. And that's where you really have to, part of the assessment is knowing the family, knowing the kid, and knowing the school. Because some schools are right there with you and others are not.
Yep, absolutely.
Okay, so from a psychopharm standpoint, we don't really think about using medications for school refusal. We use medications to treat the medication-responsive illnesses that keep company with the behaviors of school refusal. And so that may be any of the anxiety disorders, separation, GAD, or social anxiety, obsessive-compulsive disorder, or a mood disorder. The reality is that all of those are responsive to SSRIs. And so we will often use a little bit of an SSRI to either in the kid who just cannot tolerate any of the interventions from a cognitive behavioral therapy standpoint. The meds may make it easier for them to do the cognitive behavioral work and the desensitization. Other times, we can just get by with the CBT alone. Some kids, you start an SSRI and everything just melts away and they're good to go. So sometimes knowing what the family's experience, if they've had any experience with any particular medication, good or bad, can be really informative. And like in any other situation, just knowing their beliefs about psychotropic medication is going to be important, whether in terms of how hard you push to start a medicine or not. And so sometimes families will prefer to start CBT and other kinds of interventions first, but the longer the kid is out of school, as Ray was saying, the worse it can be. So it's important to sort of say, look, we'll try this, and these are the things that we're going to watch for, and if we don't make progress, let's regroup and think about the role that medicine might play. Other families just want a pill to fix everything, and we can see what happens.
Emily, in your experience, how much are you concerned about parenting imbalance between the mother and the father playing into this kind of a case? You know, there's a real psychoanalytical literature related to school refusal that tends to blame it on some of that kind of imbalance. Can you comment a little bit on that in terms of how vigilant we should be for that kind of problem?
You know, I think what we do want to look out for is when one parent is undermining the other parent. So that doesn't mean that they have to agree, but they have to present a united front. And so one scenario is that the father's fine schlepping the screaming kid to school, and the mother gets angry at the dad because it seems mean. And so those are kind of conversations that we have to have, and it's not that one is right and one is wrong. It's that they need to understand what antecedent behavior and consequence means. And so I think we take probably a more practical approach, which is we have a shared goal with both parents, which is their child be doing well. And right. So we can talk through what does that look like for each of them and create a shared vision. And then we can think about what's going to support achieving that vision and what's going to intervene. I don't think it's helpful, really, to come at it from thinking about telling one parent they are correct and the other parent is incorrect and siding. That just creates triangles, and we try to avoid triangles at all costs. So I think it really has more to do with making sure that they understand the behavioral principles that are going to drive the intervention. When things are better, then you can have a different kind of conversation with each of them or them together about how did it happen? How did they get here? And how does learning about that inform them for the next developmental blip that they're going to have to face together as parents, rather than going down there in the middle of the crisis.
Mm-hmm.
Okay.
That sounds like really good advice. Can you comment a little bit more, Emily, on your extra large size tantrum, and like what should they actually do when the kid is physically violent and hanging onto the banister?
Yeah.
You want to comment on that scenario, because boy, that happens.
Yeah. So the first thing I want to know is, what do they mean by extra large? And like, is it the frequency, the duration, or the severity, or some combination of all three? And so I really want to unpack that and understand what is severe for that particular family. I also want to understand, how did it happen that their child has become aggressive? Okay, there's a wonderful article, it's very old, by Patterson on the development of antisocial behavior, and it has to do with antisocial behavior or behavioral disruption comes out of power struggles. And so we want to have the conversations with parents about how we're going to relearn how not to have a power struggle. When kids are unsafe, all bets are off, safety trumps, but what they don't want to do is have a conversation with the youngster in the middle of the unsafe moment, which a lot of our families do. They try to use rational discourse while the youngster is banging their head on the wall, or they're screaming at the youngster while their kid is banging their head on the wall. And so we hope that we can get called to intervene before it gets that bad, but unfortunately sometimes it gets like that. And then safety and silence are probably the two most important things. So you either hold the kid and you just keep your mouth shut and you wait. And I think that's probably the most important thing, because even negative attention can be rewarding to the youngster if they are getting you agitated as the grown-up. They are getting some need met. So it's really important for parents to be able to manage their own emotional reaction. And sometimes it's easier for one parent than the other. And so we ask that parent to step in and just do this because it's too hard for the other parent, and they need to support each other. So those would be the kind of things, but safety and silence.
I was impressed. There was an article reviewing tantrums and how long they last and the physiology of it, and some time ago, AJDC, and it seemed I took away that there's a requirement that they have to last 90 seconds, and when they last, and so the key in terms of size is, for me, is to last longer than 2 minutes, because it appears that this is a neurophysiological phenomenon of arousal, and then it subsides, and I would like to have the parents understand the physiology after that. That is, they, at the end of the maximal arousal period, they are in this fragile state where they're trying to reach out to the parent, but if you look at them the wrong way, certainly if you talk to them or scold them, they're going to go back in. And so when you hear that a tantrum is more than 2 minutes, I'm assuming that something happened to reignite and persist in the arousal state, and it's clear. And I try to focus on the window before this storm, where they can avert and the logic is still present. But when the amygdala takes over, you just have to sit back and give no input, just like you said, the silence, safety and silence, exactly. I find that's the part I tune into, and I find that helpful. Thank you for Emily, that book. I haven't seen that one. And let me just say, I was just looking up something about Julius, the baby of the world.
Yep.
And he thinks her new baby brother Julius is disgusting. If he was a number, it would be 0. But when Cousin Garland dares to criticize Julius, Billy bullies her into loudly admiring Julius as the baby of the world. It looks like a wonderful book. I didn't know that one. I'm going to put it on my repertoire.
We'll get it right away.
Yeah.
So thanks very much, everybody. And thank you, Emily. Great job. That was really an interesting session. I appreciate it. It's been recorded, so I can make it available if any of your colleagues want it to.
Thank you, Dr. Harris.
Bye now.
Thank you.
Bye.
Bye-bye.